Hello, I'm Amy Rowley McGee, the president of the Health Policy Institute of Ohio. We're so glad to have you all with us today for our online forum, which will focus on the topic of community partnerships. The Health Policy Institute of Ohio is an independent and nonpartisan organization. Our mission is to advance evidence-informed policies that improve health, achieve equity, and lead to sustainable healthcare spending in Ohio. I want to thank our core funders whose steadfast investments make our work possible. And I also want to thank our 2022 Educational Event Series sponsors for their generous support of our online forum series. We encourage you to tweet throughout today's webinar using the hashtag HPIO forum. If you have questions for presenters, please type them into the chat or the question box, and we will ask them as time permits. We're also going to have some poll questions throughout today's forum and a few at the end, so please stick around for those to give us your feedback. Today's presentation slides and other related resources will be available on the HPIO website and can be found by clicking the Events tab. Improving community health, achieving equity, and promoting sustainable healthcare spending is a shared responsibility between public and private partners and across multiple sectors. A recent report that you'll hear more about here in a bit from the Lown Institute measured community benefit as a part of social responsibility for 3,600 hospitals nationwide. The report found that 3 hospitals in Ohio ranked among the top 66 most socially responsible hospitals in the United States. One way to advance community health is through intentional partnerships between public and private entities, which can often be a part of community benefit strategies and programs. We can all learn from one another on what works to improve community health through public and private partnerships. Today, our speakers are going to discuss what makes hospitals successful in becoming socially responsible, how healthcare organizations can collaborate to improve community health, how projects funded across the state will address the community conditions that impact health in health opportunity zones. And you'll also hear about examples of state best practices in organizations leveraging cross-sector partnerships and collaboration aimed at improving health and achieving equity. That's a lot to cover in a very short period of time. So we're going to just jump right in here with Dr. Vikas Sani, who is the president of the Lown Institute. He is a clinical cardiologist, and prior to joining the Lown Institute, he was in private practice for over 15 years. He leads the Institute's signature project, the Lown Institute Hospitals Index, the first ranking to measure hospital social responsibility. He is an expert on medical management of cardiologic conditions, medical overuse, hospital performance and evaluation, and health equity. Good morning, Dr. Sani. How are you?
Good morning, Amy. I'm fine. Thank you so much for having me, and thanks to the Policy Institute.
Well, you're welcome. We're happy to have you with us, and I think you now have control of the slides, so we're looking forward to your remarks.
Great. So again, thanks for having me. I'm going to give you a tour of the Hospital Social Responsibilities Index that we put together at the Lown Institute. You heard a little of my background. I am a clinical cardiologist. I also have had an entrepreneurial background, including being a co-founder of a medical device company and founding a physician network that took global risks. So I really feel like I have quite a sort of 360-degree view of the healthcare system, and I bring all that to this work. We started this work really 5 years ago, inspired by our founder, Dr. Bernard Lau. Now, Bernard was my mentor. I came to Harvard to learn cardiology with him and didn't fully understand how much he was an important thinker in several areas outside of what he was famous for, which is the defibrillator, developing the defibrillator. And one of them was in the value of care. He, for a long time, felt there's a lot of technology and some of it's inappropriately applied, and the result is a significant amount of clinical waste. So we were inspired by his vision for medicine and more generally for social responsibility. He actually maybe even had coined the term when he started a group called Physicians for Social Responsibility in his living room in 1962. But in any case, inspired by him, we asked ourselves, it's been 100 years since the sort of birth of scientific medicine in America. That was really, in many ways, a signal for that was this report by Abraham Flexner called the Flexner Report that talked about how we needed to get more scientific if we were going to have better healthcare. So 100 years later, we wanted to ask the question, well, what have we learned? What else do we need to do? What does it really mean to be a great hospital in the 2020s? And so we looked at it through the lens of 3 pillars that we feel are important, and they're going to be very similar to what, it sounds like what the Health Policy Institute looks at: equity, high value, and accountability. And so we've strive to put the Lown Hospitals Index right in the intersection of that, and I think we've made progress. So we've started and we're making progress. So this is an actual tree that illustrates the structure of the Hospitals Index. It has 3 main pillars: equity, value, and outcomes. But under that, it has a number of metrics. And the equity metrics, inclusivity is something we developed ourselves. Pay equity is something that's available, but really no one else had done this before. Community benefit spending, again, people had looked at this. There's a literature, but we were able to put it together and assign certain values to it, and then take a look at how hospitals fared. And similarly with the others, there's a lot of risk adjustment and outcomes, a lot of manipulation of claims data for value, and happy to talk about any of those in detail. But let me just say, we strive to use our data in a way that could be transparent and replicated by others. So we have lots of data. We've linked it all. But it is data that anyone else could access. I mean, it would take time and money. It took us 3 or 4 years and several millions of dollars to get here. But it is doable. It is nothing proprietary in any of this. And so we did America's most socially responsible hospitals. And so let me tell you a little bit about what those results were. So for example, Metro Health rated 15th overall. And, how did they do this? Well, Metro Health did really well on a couple of measures, like avoiding overuse. They were #1 in the state. And when we drill down a little bit about what that looks like, what we found was that, for example, just one example, the rate of spinal fusion overuse was about 9%, whereas the state average was 16%. And the rate of coronary stenting that we deemed to be unlikely to be beneficial was about 4.5%, whereas the state average was about 18%. And so that's how Metro Health did what they did. And so this lands in that middle section, the value part of what we do. And so how did we calculate that? Well, so our methodology for avoiding overuse, we have access to 100% of Medicare claims. So we're not reporting commercial data. As many of you may know, commercial data is very hard to get a hold of, especially if you want to identify individual performing hospitals. Well, we looked at 12 services that are deemed low value by many people. There's actually a big burgeoning literature on this question, and in the last decade in particular, this has been expanded. There are now some 2,500, 3,000, maybe even 4,000 various services and procedures that are deemed to be of low value, meaning the likelihood of benefit to the patient is much less than other procedures. And therefore, the potential for it being unnecessary and wasted procedure is much higher. And so we looked at 12 that could be attributed to hospitals. We used methods that were developed at Harvard and Hopkins. We've expanded them. We think we've improved them. And we're still in the process of improving, and we're collaborating with various academic institutions to make that happen. This is now fully updated to ICD-10, and we've developed some unique features to be sure we're giving the rewards to the hospitals that really could be doing these things but don't, as opposed to hospitals that just don't do it because they don't have the capacity. And so I'm not going to go into the details, but what we do is we look for a numerator and a denominator, because we're trying to combine 12 different metrics, each with a slightly different scale. We have to normalize that, and then we create a composite, and that's what you see reported for Metro Health. But we do that for these 12 procedures, and we do it for every hospital that's eligible, meaning they have a capacity to do these things. And then we just give a star rating. And that's been something that's attracted interest, not because it's new. The idea that this happens is not news, but the ability to sort of begin to connect individual locations with specific areas, we think is helpful or could help improvement efforts and efforts at monitoring and peer review and the like. So, but let me also talk a little bit about equity. This is Ohio Health Doctors Hospital. I don't know, who they are in terms of those details. I think many of you do, but they did, quite well in community benefit. And so, what does that look like? Well, what we do for community benefit is we look at charity care, we look at, Medicaid revenue, and we look at community investments that the hospital is making in other types of benefits, specifically around community building or health services that are otherwise not going to be profitable, in which there's clearly a community need. And so we add all those up, and then there are things we don't allow. So for example, even though the IRS allows health professionals education, research, and something called Medicaid shortfall, we don't. And there's a long conversation to be had about each of these. Suffice it to say that our view is that research and health professionals education are very important and are clearly public goods. But in terms of assessing the direct community benefit, they're not relevant. They're sort of more diffuse. When academic centers train physicians, they train them not on the basis of the local community's needs, but on a national platform. And so it's reasonable to think nationally and account nationally for what's going on. And Medicaid shortfall is a much longer conversation, but essentially our view is that Medicaid reimbursement to hospitals in every state is geared towards providing revenue for the marginal next patient, assuming that hospitals are essentially breaking even with everybody else. Medicaid reimburses for the extra cost, but not for additional overhead. And that's almost by design, and it's insurance products. For all those reasons, it didn't seem to us reasonable that this be counted as a community benefit for which the tax exemption, would be measured. And so when we look at that and we look at different hospitals, so for example, Doctors Hospital, charity care was 8.5% of expenses. That's 3 times the national average. And their Medicaid was 32% of revenue, which is twice the national average. So that illustrates a little bit of how that metric works. Now let me go to Grady Memorial Hospital. This again was 34th and ranked number 2 for something called inclusivity. And that's a metric that we developed in-house and that we designed to illustrate how well a hospital's patient demographics, income, educational achievement, these are sort of proxies for social class and racial background, how much those demographics of the patients that the hospital serves within their 4 walls, how well do they match? How well do they match the surrounding community, where we define the surrounding community as being a perimeter from which patients already come. So we didn't impose some artificial boundary around any hospital. We said, where do patients come from? Let's look at everywhere they come from. But then what we did do was say, well, if they can come 10 miles in this direction or this direction, they should be able to come 10 miles from this direction. And so on that basis, we try to examine how hospitals serve their communities. And so, we developed this methodology. And this methodology shows how we do this. And now we use travel time, which is why that circumference is a bit jagged, but that's roughly equal travel times to a given hospital. And on the left, we have the demographics of the patients who come to the hospital. And you can see there are patients coming from a lot of different areas. And then we have demographics of all the patients, even those who don't come to the hospital. And then we can compare the two. And when we do, for example, for Grady, do I have that? Yeah, so Grady ranked number 2. The community area income for Grady was about $56,000, whereas the hospital patient income was about $48,000. So it seemed like they were actually treating lower income people. And we can do that for education, income, or racial composition, as I said. And so here's an example from outside your state that kind of illustrates this even more. So this is a hospital, and this is the catchment area based on the patients who come to the hospital. This is our earlier method, the one where we just did it as the crow flies. So it's a perfect circle, but you'll get the idea. And then within that, this is where the Medicare patients come to this hospital. And you see it's densely focused on the 7 or 8 zip codes just south of the hospital. Now, in and of itself, every hospital has a different catchment area, but what's striking here is that it's only on one side of the hospital that it's so dense, whereas there are patients who come from all over. You can't see it as well, but it's lighter gray, but there are patients who come from all over. But if in this instance, rather than income, we looked at, say, racial composition, here's a match. Here's the matching area in where Black Medicare age, Medicare eligible patients live by zip code. And so what you can see is that proportion of Black patients, Medicare eligible Black patients in zip codes varies a lot. And a lot of them are just north of this hospital. But if you recall the prior map, there aren't a lot of people from the north of the hospital coming here. And this actually illustrates that even more clearly, I think. And so it kind of raises the question of what's driving these decisions. And clearly it's not all the hospital, or even mostly the hospital. Patients make choices, but insurance may drive it. Legacy patterns of residential segregation may drive it. So many factors drive it, but it is nevertheless a snapshot of what's going on these days. And so in this case, you can see that the community area has lower educational achievement, lower median income, and more racial minority groups than the area the hospital serves. So to us, this is a measure of inclusivity. And, that's how we get the numbers that we get. So here's an example now. There's the 56,000 for Grady. That's the community area. And there's the 48,000 for the hospital inpatient population and the zip codes that it serves. So, I'll leave it to you to judge, how useful this is or to what uses it could be put. But we believe it's a first pass at getting at something everybody who thinks about American healthcare, who's looked at American healthcare, understands there's quite a bit of sorting going on, driven by many things, insurance probably being the biggest one. And, just as a comparison to another hospital, you can see this varies a lot. So for Dublin Methodist, again, I don't know either of these hospitals, but you can see the pattern that's really different. Here, the community area income for Dublin Methodist is lower, the hospital patient income is higher. So they would get two different inclusivity scores on our rankings. So that's just a quick snapshot of what we're doing. Our goal has really been, as I said at the outset, to provide real insight and a new lens on thinking about how hospitals perform, what counts, measuring what matters to all of us. And what we're trying to do is provide ideas and initiatives to really encourage all of us to be bold in thinking about how can we change our healthcare delivery system? How can we make it more efficient, less wasteful, more just? So I'm going to stop there.
Thank you, Dr. Sani. We really appreciate you sharing some of the details behind the creation of the index. I'm going to look here in the chat box and see if we have any questions. I don't see any quite yet. So while folks are thinking of their questions, I have one for you.
Okay.
So since the time that you first released this work, what has the response been from stakeholders across the country? What has most surprised you about the response?
Well, so I would say across the board, there's the initial response from hospitals was mostly cautious, and I think appropriately so, because there's a lot here, and some of it very novel. And so, if I were in their shoes, I would be similarly cautious. But I do think that this is now, we've just completed 3 years, we're launching our 4th year. I think the level of interest is starting to rise more rapidly. I think the level of concern about community benefit spending and the tax breaks is something we're seeing all over the country. We were just commissioned in New York City to do an estimate of the tax break. So what I showed you was estimates of tax breaks on a national sample. That's what we do for our national ranking. But really, to get precise, you'd need an estimate of the tax break in each individual localities using their tax rates. So we've been commissioned to do that in New York City, and we're in conversations with others. That's attracted the attention of a lot of people, including, kind of state officials and, regulators, certainly the media. And I think it just reflects the fact that everybody is struggling to figure out, how to make healthcare more affordable. And so it's natural that questions arise about, are we getting our money's worth, as it were? So I'd say that's one. I think there are kind of, I don't know how to characterize them. They're academic medical centers that are leaders in differing areas. So for example, in the issue of low value care, or what we've dubbed overuse, We've had a number of hospitals come forward recognizing the importance of this and wanting to work with us, wanting to improve things where they saw flaws, and we've worked with them and we have improved them. I think at this point, I can say pretty confidently that I think our metric is certainly as good as they get. I'm not going to say it's any better, but it's definitely as good as they get. And we're now in the midst of, additional conversations about how the sort of racial equity metrics, the geographic pieces, how those could actually be fine-tuned. We have to do more research in that area. But how could they be fine-tuned to actually help hospitals make a difference? Even if these patterns that we see are due to 30 years or 50 years or 100 years of social policy and practice, what can we do now? And that's where I think there's some interesting opportunities, because if you can find targeted zip codes, then there are things hospitals could do. Something as trivial perhaps as where you put billboards or where you reach out, but also more substantial and consequential things like, where do you place a primary care clinic? Where do you, so I think there are ways in which people are just beginning to look at this and start turning it into more actionable kinds of questions. So we're delighted and we're happy and willing to partner with people who want to do that.
Okay, wonderful. We do have a question related to how the formula included how health systems utilize their 340B funds. What thoughts do you have about that?
Yeah, it did not. And we've been approached about this recently. Our data was used as part of this New York Times, a couple of big New York Times stories, one of which was focused on 340B. And so we've been getting that question. We're interested in looking at that. We're well aware that the 340B program, by providing, a lot of important medicines at, heavily discounted prices, provides margin and a cushion for those people participating in the program to be able to provide those to those in need. The question on the table, and the question the New York Times story raised, and presumably many others who've been contacting us, is whether or not everyone participating in the program is passing through as much of the savings of that, essentially discount as they possibly could. In other words, who is actually benefiting? Is it the people meant to benefit, low-income people, or not? And the issue there is that there's very little data transparency. So while we'd be very interested in looking at that and including measures of that, we'd want to be sure we're shooting straight. And for that, we need more transparency, which doesn't currently exist. We'd hate to label somebody as, freeloading when in fact they're all doing the right things. And meanwhile, we'd hate to label, somebody else as doing the right thing when they're freeloading. So without that level of transparency, it's hard to go forward.
Okay, so a necessary first step would be to make more data publicly available.
I think so. And I think, the 340B program is a federal program. It could require that level of transparency and reporting. And I think if we had that, then everyone could take a look. And just that sunshine might change a lot of practices without having to do much more.
Right. All right. So just one more question for you. Is cultural competency or DEI classes for physicians or other staff included in some of these solutions? I think that's speaking to solutions for consideration going forward.
Yeah, I would say, so let's talk about this. So just to be clear, so we're not reporting any of that. We're reporting using claims data, what's happening. It's a snapshot of access, who's coming, who's not. If you start talking solutions, then absolutely it makes sense, because some of what drives where someone goes is where someone feels comfortable. And if you don't feel comfortable somewhere, and this could be racial, but it could be class, right? If you feel like you're just not being treated properly, you're just not going to want to go there again. And so I think cultural competence for race and class is very important. It's one of the elements that would have to go into a multifaceted program if you really wanted to drive change.
Well, thank you again, Dr. Sani. We appreciated your remarks today, and we'll look forward to continuing to follow the work of the Lown Institute.
Thank you. Thank you for having me.
You're welcome. Next on our agenda are remarks from Bondi Woodbury. She's going to talk about how partnerships can be leveraged to community health. So some of the same themes that were touched upon by Dr. Sani and came up in the questions to his remarks, I think will be covered by Bondi, or we can cover them during the Q&A with her. She is the founder and president of Woodbury Group Consulting. She has over 40 years of experience in community health innovation. Recently, her work has focused on the intersection of population health improvement and traditional hospital community benefit. Prior to working as a consultant, she served as vice president of community benefit with Trinity Health. Good morning, Bondi.
Good morning.
How are you?
I'm well, thank you. Trying to stay warm here in Michigan.
We are here too. Okay, well, we're looking forward to your insights today.
Thank you, Amy. See if I can get my slide to move here. There we go. So I'm going to talk about partnerships, and when talking about community benefit, there's we could take hours to talk about community benefits. So, but I do want to, at the onset, talk about some context in terms of this evolution of community benefit, which has been an ongoing piece even before the Affordable Care Act was passed. This is a slide. The cartoon in this comes from Modern Healthcare in June of 2006. And this says all there was to say, I think, about community benefit in the early days prior to the ACA. That while there were outstanding programs and continue to be some fabulous programs in hospitals across the United States, that the lack of definition around community benefit really was a barrier issue from the onset. I know at the point at which I went into community benefit, it was whatever good things we could do. And so a lot of what has happened with community benefit has really been driven by market dynamics, including the Affordable Care Act, of course, as well as just the change in the way in which we view population health and the relationship that community benefit has with population health. So in 2010, ACA requirements began to put some guardrails around the work of community benefit and hold nonprofit hospitals, obviously, to a higher standard. The CHIP, the Community Health Improvement Plan, as well as the community benefit, the community health needs assessment became obviously the very, very key parts of all of that. And really, I think from the onset began then to force us to look more more specifically at what was going on in the community benefit office. But we always take this out of context because other things were going on in hospitals at that time. We were looking at changes in terms of how people were going to get paid, how providers were going to be paid. We began to talk about things like population health, about patient-centered medical homes. And so you have these two pieces of the internal system kind of going forward now with things that were being defined by the ACA and by outside factors. And how were they going to mix? How were they really coming together? So 2014, by then I was in community benefit, and I still remember this article coming out from Modern Healthcare and the picture about, gosh, if you really are going to be serious about community benefit and you're going to be serious about population health, the time was, this was the time to begin to focus in on communities. What was interesting to me about this article, and I've mentioned community benefit, but in fact, it did not mention community benefit. It just said, gosh, there's not a payer for this, which was always sort of interesting because you think, okay, what is community benefit if they don't identify community benefit right as a payer, or at least one of many payers? So Modern Healthcare, a few years later, in 2016, said not-for-profit hospitals that dominate the healthcare system want to become health stewards of good health and populations in their catchment areas. You can't just be a sick care institution. You have to look at community benefit. So I do think, since that time, we've relied a lot upon tax forms to tell you the whole story of community benefit. And frankly, I think that's a very limited way of looking at community benefit. I'd like to spend a little bit of time, first of all, talking about barriers, and we can talk then later a little bit about programs. Barriers to community benefit have been there from the onset. And so if you think about the fact that community benefit in and of itself is really kind of segregated, it was sort of traditionally segregated within a hospital system. You'd have a little office, somebody doing community benefit, maybe they were doing marketing as well. And now suddenly you're going to go out and you're going to engage with the community. So there were a lot of barriers that hospitals had to overcome, not the least of which was the capacity of the staff to be able to go out and do that. If you only have 2 staff and you have this wide swath of geography or a very urban setting, how do you get out and really begin to put those partnerships in place? There's also that willingness of a hospital to come out of the comfort zone. I mean, hospitals are large institutions and their job is to fix people when they get sick. And that's a little different than, okay, we're going to move upstream. We're going to look at root causes. We're going to examine what's going on in people's lives. Very different kind of environment for them. And also we found this, and this was left over from our pre-ACA days, that the programs and goals weren't aligning with the community. So the things that we might want as hospitals saying, well, we need to get everyone to quit smoking, may not work at a time when communities are looking at fentanyl. So there's that piece as well. How do we align better with communities? And the other piece is, which exists today and continues to exist, and you'll see it across the 3 sectors here, is anxiety about payment, anxiety about what's going on in the economy. And there are other pieces there, but I really want to focus on those 3 that are underlined. So community-based barriers. So at the community level, the other barrier issue that hospitals had to address is the fact that community-based safety net resources are also not aligned. If you've worked in community nonprofits for any years at all, you realize there's a program here, there's a program there, there's a program here. How do you know who to partner with? And how do you get to shared objectives about what that work is? Reality is too, as we talked about or noticed earlier in terms of the Modern Healthcare article, is that there were things happening in the community. There were programs out there. There've always been programs out there to deal with the homeless, to deal with people who didn't have enough to eat, but that alignment hadn't taken place. And so that issue of alignment has really become primary over the course of these last few years. How do we align these services with the needs of the hospitals, and that cross-sector alignment with the hospital, with the nonprofits as well? Because they would say, well, who's going to pay for extra work that we're going to do? They also have current anxiety about what has happened, certainly since COVID. Many nonprofits and safety net structures in the United States today received a great infusion of funding during COVID, and now that money is going away. And during the time of COVID, they hired people, they did more. So this is another barrier issue that we're going to be looking at and probably facing in the future. And finally, resident-based barriers. So we very often talk about the nonprofits and we talk about the hospitals. We may talk about government, but it's very rare until recently that we really spend some time saying, well, what do the residents think? What do the people who receive these services think, and what do they want? And in looking at that, if you survey, and many of us do as part of our community health needs assessment, one of the things that will pop very quickly is this historic lack of trust in institutions. And it's not just hospitals, it's government, it's school systems. And we've seen that sort of amplified recently. And so that also creates a high level of anxiety in terms of, gosh, every time you come to us and you want to set up a program, it's a top-down kind of piece. And we're kind of sick of that. Much of the polling that we've done locally, and I've listened to other the hospitals that I've consulted with, talks about, well, this is a one-sided relationship and it has to be two-sided. What do residents want, and when do they want it, and what do they prioritize as opposed to what we prioritize? All of those important to community benefit. In the end, no matter where you are, it's all local. So the health status impacts, as you can see, just about every element of life. So if we're going to talk about social determinants or social influencers or however we term that, it influences whether people can get and stay in a job, whether if their transportation is failing and getting to a job and their transportation fails and getting to a medical appointment, what's the real difference? It really speaks to the nature of how we need to align all of these resources at the community level. And the point, the part of that, it really is the responsibility of community benefit in terms of being a motivator for some of that work, as well as opening up these channels of communication with other groups within the community. The community, all communities are different. You've seen one, and they all churn in their own way in terms of their environment, their needs, what they have, what they don't have, the assets on the ground, et cetera. So this isn't easy work. And I think we sometimes, again, tend to say, well, community benefit, great, money, yay, but that isn't enough. So the community benefit bullseye is really getting ourselves outside of the walls and looking at all those multi-sector barriers that we really have to deal with if we're going to improve health. Part of that being, of course, the needs assessments, and the other pieces being alignment of resources, how we can partner in meaningful ways, building trust with residents, and measuring. Because the other piece that we really didn't do at the onset was we counted heads. We didn't really measure our impact, which also has become more and more important as we begin to look at what is the return on investment to a hospital and the programs that they're setting up or the programs that they're supporting. And that puts additional stress not only on the community benefit office, but also on the community members or the community organizations that you may entrust with some of your funding to take care of a particular issue. So Don Berwick said it best, it's a community by community piece that we all need to work on. And if you're going to redesign the healthcare system, you've got to pay attention to communities. So we're going to talk a little bit about change. So that intersection of population health and community benefit, community need, I still remember when I was at Trinity getting a call from our population health department and them asking, do you have community health needs assessments? And at that time, I think we had 91 hospitals, somewhere in the 90s, or 90, 91, 92. And we had copies of everybody's needs assessment. And they said, well, can we have them? We want to read them. For those of you who've worked in community benefits, like, ooh, who wants to read a needs assessment? Those are data books, but those data books can be really one of the most profound tools for a hospital system, as well as for their community. This isn't just an internal thing. Those needs assessment could point out where the risk was, who was really falling behind, what were the sorts of things we were investing in, where were the linkages for referrals. And once population health and community benefits sort of joined arms in terms of we both have a center here, a piece that we need to do, that then really began to become a pivot point in how we began to address community benefit. So internally, we start to look at, and most hospitals did this, so where were those intersection points with the community? Where were those linkages? And you could go across and you could say, well, okay, we're doing population health, or we're doing clinical programs, we're doing some access, and there's compliance. But throughout looking down, as you thought about all of those things that were going on in community, well, these were natural partnerships that we needed to become invested in, depending upon what our needs assessments were telling us. So whether it was looking at equity and disparity and root causes in certain parts of our communities, the use of community health workers, which was really catching on, frankly, again, after the ACA, and as we began to look at community clinical linkages, uninsured populations, we still had uninsured people after the ACA, outreach. There was a wonderful wealth of community programs in our communities that we needed to touch and we need to bring in the fold and to talk to them about how we can better partner. And one of the best ways to kind of think about this is, I really kind of like this slide in terms of what it tells us. So somebody has asthma, they go for treatment, both maybe at the hospital level, maybe it's at the primary care level. Well, that doesn't stop there. So we began to look at who else was involved in these sorts of issues that were important issues to the hospital, obviously important to the patient. Well, there's the intervention piece that has to do with, what other services does this person need? Where can a community health worker, for instance, begin to put pull together the various resources that would help deal with the underlying causes of asthma. We began to look at safety net services. What other things did we need to do? I mean, was this at-risk housing? Were there things going on? Was this a house that needed to be refurbished? Was there better and more safer housing, if you will? What was the role of public health in looking at that? Environmental, government. So in looking at the holistic view of health and community benefit, this really then became sort of the next game in terms of, okay, we can see where these pieces are. Again, how do we align it? So the alignment, the first step in alignment was the community health needs assessment. I think it was a gift to hospitals, and some people in hospitals may say, oh, no, but yes, it was. I mean, the wonderful thing about a community health and needs assessment is it really can be the most powerful tool in a toolbox. Because if you approach it in the right way, which means as you're planning for your assessment, pulling together your collaborative team. What is a collaborative team? Is that internal? No, you bring in people external. Ideally, you do a consolidated needs assessment. Who else in the community has to do some kind of a needs assessment as a condition of their funding? HARAs, the housing folks, the Head Start people, public health, who of course is required by the ACA, pulling those folks together at the table because you're all really on the same journey of getting the best possible data and discerning what it is that you need to do an intervention on. So that collaborative team becomes very important. The other part of the collaborative team is how do you then integrate into that authentic community voice? Too often in the past, and I'm not just talking about hospitals here, but when we're doing assessments, we forget the authentic community voice and we rely instead on nonprofits to serve as proxy for community voice. If we really are going to change community health needs and address the disparities, then we have to talk to the people themselves. And that's tough if they don't trust you, but there are various ways that you can do that. In terms of scope, that geographic service area we've already heard is extraordinarily important in terms of thinking about where's the service area, where are those vulnerable populations, and again, getting at that authentic voice, getting at having those community members tell us what they need. One of the best ways to do that is simply going and entering into a relationship with a trusted community resource. Maybe it's a church or a nonprofit that has been there for years, that is trusted by members in the community, and doing a resident-to-resident survey. You know, what are your hopes and dreams? What gets in the way of them? People will tell you what their social determinant needs are, their social needs. They'll tell you where the deficits are in their community. They'll also tell you the positive things that they're proud of. I think that one of the aha moments for everybody ought to be when you're dealing with under-resourced communities is their great pride. There's enormous resilience in people in community that sometimes gets washed over in terms of, well, we're here to fix things. We aren't there to fix things. Really, the power of fixing things is at the community level by those residents. We also looked at, obviously, through the needs assessment, it's data-driven. Data-driven gives us a place to start and a place to measure as we go along, and we look at the secondary data, again, the community surveys, and that emphasis now on place-based. How do we really get at root cause analysis and the disparities that go on in certain areas of our community, and how do we lift those up and really begin to really think through how we prioritize those interventions. So, alignment. What often happens when people do needs assessments, or hospitals do needs assessments, too often is you break up the group when you're done. And to some extent, this is the fault of the federal government, who didn't say as much about community health investment plans as they did about community health needs assessments. So the plans themselves, I mean, it's really, well, we'll all go home and we'll all do our plan. I would argue that's not the way to go. If our end goal really is to align services and to maximize as much investment in those community needs as possible. So whether it's a collective impact model or other models that are used to keep people at the table, to look for those opportunities for joint investment. If you're going to, say, focus in on something like childcare or some community building piece, then it's really, really critical that you maximize the investment and you look at solid goals and you begin to measure across those boundaries of all these different stakeholders. So that becomes extraordinarily important if you're really going to have the impact you want on communities. Maintain your data committee. I've never understood why, you know, everybody's okay, we've gathered all this data, we've got this great data, we've published this data, now let's wait for 3 years and do another data thing. There are all kinds of resources now where you can maintain data, and what better place to maintain data as well as to begin to reach across these boundaries than to do it at the community level. There's no way you will ever align all of the needs assessments by all the various groups that have to do needs assessment on a calendar basis. But that doesn't mean you can't continue to work together to update data as it comes in so that it's always available to community members and to whatever entity is now in they're on board in terms of having to do their next needs assessment. That's a waste of resources when we walk away from data, and data ultimately, especially if we can use all sorts of tools in terms of putting that data front and forward with our communities, that data is really what runs a process. Let's see. Oh, it is sticking. Sorry. Let's see if I can get this going again. So few examples. So this is an example of one actually from my hometown, which I figured I'm gonna brag about my hometown. After our needs assessment and the community benefit, the CHIP was done in Muskegon, one of the other things that we did as a community is we pulled everybody together under a vision of creating a livable community, shared the community benefit data in terms of what came out of our needs assessment, began to identify livability elements, and then you'll see in the circles all the way around, all of those are actually, if you go online and you poke into one of those circles, it will give you the data, not just the qualitative data, but also the quantitative data, what residents said about those particular issues. And then what we've done is we invited members of the community in. We really emphasize getting residents in and business, and not really business because they're dealing with the same issues, put them all in a room and said, here's the data, go for it. So we follow what's called a 100-day challenge, where teams are formed in 100 days and they take on various elements of some of these, social determinants or major barrier issues in the community, and they try to fix them as a team. And we've had some wonderful outcomes from that. They all receive a coach. They work very quickly. They are very diverse. They have strong community resident voice at the table. It's been a really fun process. Rhode Island has done health equity zones. We've talked a little bit earlier in terms of the work that's done on a place-based approach. And Rhode Island, in their development of health equity zones, decided when they received one of the federal, I think it was a state innovation grant, it was one of the CMS innovation grants, that rather than doing a top-down approach to solving some of the issues inherent in their Medicaid program and other things, is that they would instead convene residents themselves and have the residents drive those processes. The entire state of Rhode Island is divided up into equity zones. Those equity zones look at everything from food accessibility to economic development, and they've really done a beautiful job with that. It's a very different way of approaching work in a community that breaks it down in again, you have very authentic community voice, the nonprofits at the table and the hospitals at the table, of course. And all of these models I'm referencing have hospitals at the table. And so in a place-based intervention, you'll see at the top, social determinant factors, and then the alignment then using this kind of a model where you've identified all of the various programs that fit within these individual buckets, and then using that then as the basis for community-based planning and looking very strategically at place-based types of investment. Another thing about place-based investment is federal census tracts. Use federal census tract because they can be wonderful. And there's been so much more done with federal census tract data than in the past, done by the Robert Wood Johnson Foundation and others, where you really can now, almost irrespective of the size of your community, really begin to really focus in on where you have under-resourced communities and where years of life really varies from more upscale parts of your community. So in our community, we've used it, and And on one side of a road, people live 10 years less than people on another side of the road. I could show you the map. I didn't include it in this, but it's very clear where investment needs to take place and where people need to be mobilized and assisted in any way that they want. Social determinants of health. We finally started, I think, across the country. Everybody is looking at this a little bit differently, but most health systems and most community groups are now looking at the various indicators in terms of social influencers. And this is wonderful data for needs assessments. We didn't have it at the beginning when we started doing needs assessments, but this really gives you a frequency count. If you're using it in a health system or as part of a primary care network, you can look at frequency in terms of, well, where are the issues that really need to be addressed in the community based on frequency of need, and what does that tell us about where we need to maybe be shifting our investments to a different part of the community. Isn't enough just to do that, and I would be remiss in not mentioning Mark and Sarah Redding's work out of Mansfield, Ohio, the Pathways Community Hub model, which is it's an absolutely fabulous model. Mark and Sarah, based upon the work they did, they're both physicians, looked at this, at how do you, again, align these resources. They're probably, I mean, if I think about what was going on in the hospital and the ACO and all of the things that the hospital needs to do, and having this hub, this external hub that then had the ability to take referrals from medical providers, as well as take referrals from the community itself, and help to navigate those people through the extensive use of health workers into the resources in the community that they could then get some help from. I mean, the model itself is data driven. It's had marvelous research done on it to show the impact that it's had, but it is exactly the kind of resource that communities need to make sure that care coordination is done in such a way that's efficient, effective, and you can get data out of it. And finally, I'm going to close with this. Back in the day before the ACA, much of what was done at the community level was done through community health networks. And many of these community health networks are still in place. And one of the things about community health networks that I dearly love, and I think it's probably something that I think, especially in this environment we're in today, where we know we have a lot of people who are not using medical care in the way that they should because of cost or other factors, other barriers, is the fact that in community itself, there are a variety of models that really are there to help be intermediaries to help get people the care that they need. Early on, as when we didn't have ACA and people didn't have coverage, these networks began to put together a list of programs that we call them the 8 critical activities that really represented, if you were going to knit together a process, this is what it would look like. And so I would, on this particular slide, you may want to take a look at it, because I think you'll find as you go through it that all of the various elements of what a community benefit office can do is embedded in this work, and it's also embedded in these community groups. And many of them, at least everyone that I've ever been aware of, had hospitals at the table. So that's pretty much what I had to say about community benefit. And with that, I'm going to turn it back over to Amy.
All right, thank you. Thank you so much, Vondi, for your remarks. We have time for just one quick question. And this question is related to the role of payers and health plans in linking the various silos. So instead of there being a 3-legged stool, a 4-legged table. What are your thoughts about that?
Oh, yes. I mean, the health plans, I didn't spend time on the health plans in terms of community benefit, but the health plans, for instance, there are places where health plans really can be, first of all, where we can help the health plans, the community can help the health plans, and the health plans then can help the community. Not the least of which is, again, looking at the frequency and risk stratification of social determinant indicators. That's number one. They need to know that as much, in every bit as much as the hospitals themselves. Secondly, their ability to invest, especially if they're nonprofit health plans, investing in groups, say like entering into contracts with groups like the Pathways Community Hub Institute, investing as a health plan in some of the place-based efforts that are going on around the country, where, I mean, you know, all of these things cost money. It isn't just the hospital's job to fix all of these things, but the payers have a role to play in this, local business has a role to play in this, and government. So we need to think about braiding our funding, blending funding, and those sorts of approaches that really then allow us to have the impact that we really want to have at the community level.
Okay, wonderful. Well, thanks again for being with us today. If you don't mind sticking around for just a bit, if there are any other questions for Vondi, please type them into the question box. And if she has a moment, she may be able to address some of those. We are now going to do a quick poll, and we invite you that while you're responding to the poll questions to move around a little bit, stretch. So I see Alana has put up the first set of poll questions, and we just want to get a read on how you're feeling so far with the content that you've heard, and what your thoughts are related to the usefulness of the information that you've received. Please remember to scroll down in the poll question box. There are a total of 4 questions. It should just take a few seconds to reflect and respond on those questions. Again, we appreciate you all being with us today. We had a great turnout and a lot of folks are sticking with us. We have 2 remaining terrific speakers. In fact, you heard a little bit about Rhode Island's health equity zones. You're going to hear about Ohio's take on that concept from Jamie Carmichael next. And then we'll close out today's session with remarks from Dr. Lauren Smith, who is with the CDC Foundation. So please remember to stick with us here. And Alana, are we about finished there with the poll?
Yeah, we can close it out. Thanks, Amy.
All right. All right, well, let's move now to our next speaker, who is Jamie Carmichael. Jamie is with the Ohio Department of Health, where she runs the Office of Health Opportunity. She previously served as Deputy Director of Public Affairs for the Ohio Department of Mental Health and Addiction Services, and provided nearly a decade of service to the Ohio Department of Job and Family Services, working on policy initiatives involving workforce and minority health. She's going to talk about the work that's been underway within the Office of Health Opportunity, including the work related to the Ohio Health Improvement Zone. Good morning, or wait, now we're in the afternoon. Good afternoon, Jamie.
Good afternoon. The day is flying by for me today. I don't know if it's the same for all of you. Thank you, Amy, and thank you to your colleagues at HPIO for hosting this event and for including us here at the Office of Health Opportunity. We're really grateful to have the chance to share with you all today a little bit of what we're doing here. We are a new office, and so it's good to share and give updates. Am I okay to share my deck? I think you guys have it too, but I can share from here if that's better.
I believe that Alana was going to give you control of the slides.
Oh, okay, wonderful. Sorry. I'm not a Zoom person, so government we use Teams, and so Zoom is like disorienting.
I understand.
Whole new setup. All right. So I have control of the slides.
You do, Jamie, but I'm happy to move them for you as well.
Okay, yeah, I don't know how to do it. Oh, wait, I think I just did it. Or maybe that was you. Either way, I'm Jamie Carmichael. I'm our Chief Health Opportunity Advisor here at the Ohio Department of Health. My position was created in response to Governor DeWine's Minority Health Strike Force, which was formed really at the height of the pandemic to try and deal with the issues that were driving the disproportionate impact of COVID-19 on minority communities, especially African American and Latino communities across our state. And not surprisingly, what we found is that COVID is kind of just a byproduct. The disproportionate impact of COVID was a byproduct of a lot of other inequities in our system. And so our office is really focused on going after those inequities. So I'm going to try and move my, oops. Sorry. Our mission here in the Office of Health Opportunity is to ensure all Ohioans and all Ohio communities have a fair and a just opportunity to thrive. We're going to talk about that. This, if you all have heard me before, this mission has evolved and it will continue to. We've been in office now for a little over a year. And at first, I would come out and say, our mission is to eliminate population level health disparities in our state, not reduce them, eliminate them. And certainly that is still a key goal for us. But in reality, when we dig into what has to happen for us to get there, we have to, embed fairness and justice in our processes and helping all of our communities be places where it's not hard to be healthy. So we're doing this through a variety of strategies, but our general approach is we have to prioritize the highest need communities. We cannot spread the peanut butter, super thinly. We have to share power with the people in those high need communities, and we have to build strong collaborative relationships across state government and, vertically, and with our nonprofit and for-profit partners. Everybody has a role to play in making Ohio a healthier place. So we're really starting with data. That has been a key priority for us since day one. I'm going to talk to you a little bit about some of the data work we've done. We're focused on building new partnerships and building capacity, not just for us here at the department, although we have work to do on building capacity for really centering equity. But working with our local public health, working with our local ADAM boards, working with the hospital systems, trying to help build capacity in grassroots and in faith-based organizations and in other small CBOs so that they can be a voice for their communities. Oops, so sorry. I really don't know how to use Zoom. Right. Okay, so our Ohio Health Improvement Zones. When we started out, we had like one vial of vaccine for a state of 11 million people, it felt. And we were really trying to figure out how do we prioritize who gets in line first? And we decided to go by vulnerability. Who are the people who are dying? Who are the people at highest risk for getting sick from this disease? And the CDC has already been thinking about this. They think about this for emergency preparedness planning, right? And so they have this thing called the Social Vulnerability Index. It gives every single census tract in our country. So census tracts much smaller than zip code. These are basically neighborhoods, essentially. It gives these census tracts a score on a scale of 0 to 1. If you are a census tract with a score of 0, good for you. You are in a healthy community that is ready to respond to a disaster. It means you don't have concentrations of mobile homes. You don't have overcrowded housing. You have access to transportation. If you have children, you probably have lots of multi-generational or two-parent households. You don't have high concentration and density of people with disabilities. That's what a score of 0 kind of looks like. On the opposite end of that spectrum is a 1. And if you are a 1, then you have a lot of barriers to being healthy. And they actually look at 16 different components to generate this score, okay? And it's not just health outcome data. It's actually looking at the environment to see, housing and transportation. How likely is this to negatively impact your ability to respond to a disaster? So what we decided in Ohio is that, hey, every census tract in our state, every neighborhood that has a 0.75 or higher on that social vulnerability scale should be a place where we focus resources, not just for COVID-19, but for public health and public service generally. And so we created the Ohio Health Improvement Zones. These health improvement zones, again, the 703 or so right now communities that have that score of 0.75 or higher. All right, so we've been using the health improvement zones in a lot of ways. I talked a little bit about, prioritizing vaccine efforts. So we have 6 mobile vaccination units, for example, out right now who also do health screenings. And we are prioritizing those 703 neighborhoods. We want to go into those neighborhoods, offer people the opportunity to be vaccinated. But we also are, prioritizing the Ohio Health Improvement Zones in the schools that serve the Ohio Health Improvement Zones for expansions of school-based health. We have a community health worker grant that we just announced the grantees for, I think 2 weeks ago now. And we're only funding folks who said they were going to expand community health work in the Ohio Health Improvement Zone. So we're really trying to push investment and concentration in those communities. All right. So one of the things we do in public health, we have a lot of epidemiologists, and epidemiologists are awesome. They're very smart. They're great with data. But a lot of times we'll get data from our epis and we'll say, this community has a heart disease problem. And we'll go to our book of evidence-based practices, to our database, and we'll say walking club and maybe a community garden are great community-based practices. Let's go do it in this area to address heart disease or diabetes or whatever the disease state is. And the problem in that is that we don't always include equity, right? We haven't taken a second to talk to the community. We haven't asked the community what they think their biggest barrier to health is. Instead of rolling in this paternalistic way with, hey, we know your problem and we know how to solve it, please step aside and let us help you. We're trying to take a different approach that centers and values the community's experiences and their perceptions and puts them in the driver's seat and assumes that they are the experts on their health. And that's a hard thing, you guys, for folks who have been in the social service world. And I'm finding that as we implement the Ohio Health Improvement Zones, that's a stretch for folks. It's a different kind of thinking of, instead of I come in and look at my data and tell you what's wrong, if I go to your house and you tell me your biggest barrier to health is not heart disease or diabetes, but your biggest barrier to health may be community violence, then I want to fund community violence interruption. And I want to fund a walking club in a community where it's not safe to walk, right? So we really needed to figure out, how are we going to put communities in the driver's seat on, and how do we put the Ohio Health Improvement Zone communities in the driver's seat of their own health? And so we developed this Ohio Health Improvement Zone project based on the Rhode Island Ohio Equity Zone, or not Ohio, Rhode Island Equity Zones. We said, look, we need to do this here. I'll say this, Rhode Island's model is amazing. I have spent many hours with them, over the last year and a half, actually, even before this office was established. But, their population is a lot smaller than Ohio, right? I mean, I think they have less than 3 million people in the entire state. And that's like, a metropolitan area in our state, right? Of which we have like 10 metro areas or something. So we really needed to adopt and develop our own model here in the state. So this is kind of what we've come up with. The Ohio Health Improvement Zone is this place-based initiative. It's really centered on equity and addressing social determinants of health and putting communities in the driver's seat. We actually have around a $10 million investment in this project. $6.89 million out to the community, and we're investing quite a nice chunk of money in evaluation. And I'm going to talk about why that is here at the end of the presentation, but max award $500,000 per entity. And again, challenging folks to connect with communities in a meaningful way and put them in the driver's seat. We have an expectation for each of these grants that they'll have private, public health, and nonprofit partners at the table, that the community is engaged in meaningful ways. I'm not talking about like a community meeting at 6 o'clock that not even I'm going to go to, but really engaging the community, meeting them where they are, and using the data that's available. We have some basic expectations for the grantees around, how we hope that they're operating, right? So we're centering equity again and saying, hey, equitable cross-sector relationships really focus on convening and not leading. This is about convening people, not leading, and really, again, keeping the community intimately involved. So developing these community partnerships, we're paying for them to establish these cross-sector connections, and we're paying for them to plan. And you can essentially be funded. We have 3 funding categories. You can be funded as a key activity 1, key activity 2, or key activity 3, because we recognize that many people in the state are already doing this work. And we don't want to slow that down and make people backtrack. We want to invest in what's working. But at the same time, we wanted to seed, where it made sense, opportunities for people to engage in a new way. So key activity 1, these are the organizations that are really focused on community engagement right now. They're really focused on building those cross-sector teams. For the key activity 2 folks, they were able to demonstrate in their grant applications, hey, we did this. We didn't just do a survey. We actually did meaningful community engagement out here. We have partners. Here they are. They're in lockstep with us on this. And so for them, we want to fund implementation, right? We want to actually get their projects off the ground. For key activity 3, this is for the folks who already did all of that. They implemented it. But we all know how funding is. It comes and it goes. And we really wanted to allow people to sustain and to build on what was already working, those community developed, community-centered and driven approaches to addressing social determinants of health. And this could really look like a number of things. So for key activity 1, for example, in Youngstown, for each area they've recruited community health workers. So they're using their grant. They have another investment from the city of Youngstown to match with it. And they're developing these community health workers in each area, and the community health workers are organizing the local health improvement partners, the churches on the corner, the mosques, the community centers, the all the homeless shelters, to really help with the community engagement and talk to people about what they need in their communities to be healthy, right? So that's an example of like a good key activity 1. Key activity 2, we have folks who are like, we're there, we're ready to implement. So we have another example also, I think from Northeast Ohio, where the partner is saying, hey, we're ready to implement and we want to use your funds, Ohio Department of Health, to do that. But they've also brought CareSource along. Somebody asked earlier about connections to managed care plans. They contacted CareSource and said, hey, we can't pay for X, Y, and Z with this ODH money, but we think that we need this other part to make a cohesive project and to really succeed in implementation based on all of this other stuff that we've done around planning. And CareSource said, sure. So they brought their private money, has a lot more flexibility to the table, right? So those are some examples of some of the projects and how that's working. Speaking of partnerships, we did require that they come to the table with non-government partners and with non-health partners. That could be in-kind contributions, and a lot of it is, but we also have almost $1.5 million in non-federal funding matched with these federal funds that we've put out to really try to ensure that we have some sustainability and community buy-in. Altogether, there are 26 subrecipients, grantee awards, and we're funding projects in 211 communities across the state. And every single one is informed by the people who live there and centering them as the decision makers. We do have some challenges to implementation. And I mentioned this earlier. This is a new way of thinking. It's so tempting to look at the data and be like, oh my goodness, look at this lack of green space. We need a playground. There's 200 kids who live in, maybe a 4-block radius, and we have no playground. We need a playground. Well, time out. Did you ask the community? Did you talk to the youth? Did you not just the adults and not just the community leaders, but did you talk to the people to ask them what they think they need for their community? Let's take a breath and do that. And I think that has been a new way of doing things for folks. And the grantees have been wonderful and flexible and willing to learn and change their approach. And we've all just kind of been learning together. It's really, really cool. I think figuring out who those partners are in the community that really have real meaningful influence in a community has been a challenge. We're so quick to go to a pastor or, and especially in the Black community. It's always like, well, have you talked to the churches? Well, guess what? Not every Black person goes to church. Not every Black person's a Christian. That's not, they're not talking to everyone. That's not a holistic view. So let's really think about how we get to the most vulnerable folks in our community. Who's in relationship with them on day to day, and how do we engage them and get them the funding they need to really do their work, but also engage the community to find out what else is needed. Cross collaboration between all of these subrecipients has been key. We convene them a lot, and they have lots of opportunities to talk to one another, to learn from one another. We do weekly, we have all kinds of technical assistance stuff for them that we do. I do want to talk really quickly, I'm just about at my time, on impact evaluation. And we're looking at the evaluation in two parts. I mentioned that this is key. Unfortunately, this is one-time federal money. And the reality is that even though we've requested an extension from CDC that I think we'll get, knock on all the wood, it's one-time money. And so we really want to make a good business case for this model, for this approach to public health, for this approach to government. And so we are looking at the evaluation in two parts. We have, some core questions that are really looking at the impact, like what was done, how well were they delivered? More importantly, how are the people that were impacted here better off? Those are the questions we want to answer. We also want to look at our process, right? We also want to understand, was this done in an equitable way? Because again, we're not only trying to get to an end of developing a service or delivering a product to a community. A big part of this, and I cannot overstate it, a huge part of this, we are not successful, and I will go out and say we are not successful unless we have effectively engaged communities and put them in the driver's seat. We cannot achieve equity without the people that we're trying to help in the driver's seat. And so we want to know, does this process work to center community? So that's the other big push for us in the evaluation process. I do want to make you aware, I have to do my shameless plug of our new social determinants of health dashboard. If you have not seen it, I'll definitely drop a link in the chat. There are over 120 publicly available data sets out there mapped at the census tract level, so you can see what's happening in the community where you are. We have multi-generational households. Where are they? Where are the ones that are just led by grandparents, right? Where are the food deserts? But not just where are the food deserts, where are the food deserts with poor people in them? Because that's different. So we have all of that data out there for all of you as you start to think about how you engage in the social determinants of health to really support your work. And then please sign up for our newsletter. We put this out every week. We really try hard to get it out weekly. If you have questions or just need more information about anything, you can always email me or email our health opportunity at odh.ohio.gov box. So that is it for me. I think I did that in 20 minutes.
I think you did it. I think you missed a calling and could have been an auctioneer.
I was talking really fast. I was, I'm sorry.
Well, maybe later on, when you're wanting to change, you could go into that field.
Thank you.
Well, if you don't mind sticking around a bit, Jamie, I think we're gonna move on to our next speaker, but we've invited folks to put questions in the Q&A box. So if you have a question for Jamie, please put it there, and she'll spend a few minutes answering any questions that show up in the box. Let's see, now I just need to get myself back organized again here so that we can move on to Dr. Lauren Smith. as I mentioned earlier, she is with the CDC Foundation, whereas she is the Chief Health Equity and Strategy Officer. She's going to talk about partnerships to improve community health. She has a long history working on community health issues. Before joining the foundation, she was with FSG, a leading social impact consulting firm. And in the past, she has worked with many leaders in the community, social sector, public sector, healthcare, public health, philanthropy on these issues. Welcome, Dr. Smith.
Thank you, Amy, and thank you to the Health Policy Institute of Ohio for inviting me. I first just want to say, wow, what a great lineup you have had this morning. It's such an honor and privilege to follow these excellent speakers. Definitely hard acts to follow. But your planning was outstanding, because I think we can drill in a little bit to some of the specific characteristics really that Vikas, Vandi, and Jamie all alluded to in what I'm going to talk about. So I think people will be able to see the through line. Great. So I am with the CDC Foundation, which is a nonprofit independent entity that was created to support public health protection work of the CDC by mobilizing philanthropic and private sector resources. And so earlier this year, we launched a series of virtual national summits on the future of public health, and tackled multiple issues, including data modernization, which has been alluded to already in terms of being able to sort of share data between government and nonprofits and community entities, as an example, workforce preparation within public health, and then public health law and financing. But the last in the series that we did was focused on cross-sector partnerships and community engagement. And so what I'd like to do with my time is share a few of the highlights that came out of that day-long virtual summit that included 1,800 participants from across the country, from public health, state, local, and federal public health, as well as business partners, healthcare systems, and other community-based organizations. So it really was a wide cross-section of groups. So we called it Lights, Camera, Action, the Future of Public Health National Summit Series. And so the very first thing I like to sort of talk to you about is really to pick up the theme that Jamie just was talking about, which is around the value of partnerships. And again, this is coming from all the folks that were participated in the synthesis of what they contributed. So one of the first things that people brought up is that having partners and effective partnerships really maximize resources that are available. And one of the quotes was that with partnerships, 1 + 1 can often equal 5. And by amplifying resources and reaching more people, gathering like minds, you really have a way to harness power. So that ability to maximize resources. And I think you heard Vandi was talking about the blending and braiding of multiple kinds of funding: federal, non-federal, private sector, philanthropic. So this gets at that. Existing partnerships can facilitate preparedness. And this really, I think, is illustrated by this quote, which is referencing partnerships that were developed to address Zika when that infectious disease first came out. But during COVID, even though the health threat had shifted, so much of what was there in terms of the partnership ecosystem, and I love that term, the partnership ecosystem, was essential and gave the response a jump start, right? So they didn't have to start from scratch developing relationships, which can be hard, and we'll get to later. Partnerships can protect and support public health against threats and opposition. And I'm sure if I had an opportunity to ask Jamie this question, the idea of public health being on the front lines and receiving so much opposition because people were unhappy with some of the recommendations around, social distancing or wearing a mask, that kind of thing. But having partnerships that can corroborate and lend their credibility and their social capital to the conversation can really help buffer some of that adverse effect on public health. So we asked the group, again, this 1,800 folks who joined, what are the biggest challenges to establishing the kinds of cross-sector partnerships that you've been hearing about this morning? And this is what they shared. The biggest challenge was a lack of flexible funding, or only having funding that is disease and sometimes just organ specific, right? So not the kind of funding that can go into broader kind of initiatives that are important in building partnerships. The second, around difficulty establishing mutual trust among potential partners. Again, you've heard some allusion to that already. And then this next one, I want to call out this power imbalance. And Jamie mentioned this a lot about, centering the community. And that really requires acknowledging and specifically acting on how are you going to think about power and how power is distributed differently. So some of the best practices and partnerships that this group of practitioners wanted to share was around intentionality and transparency. That is, they don't happen. Good partnerships, effective partnerships don't happen by accident. One has to put effort into them, and one has to be clear and transparent around what your goals are and why you're coming together. I think probably one of the most important things that resonated for me was investing in transformative relationships versus transactional connections. Like we're in this to, exchange something as opposed to build something that's going to transform our community and that's going to last beyond this particular project. One of the quotes that came was, I've seen projects go, they're short-lived, they're unsustainable, and they were built without ever asking the community what it is that the people want. They never ask if this is what they want for themselves. That, I'm sure, sounds really familiar because that's exactly what Jamie and Vondi were just talking about. So that theme definitely resonated with our group as well. Ensuring community ownership and engagement from the beginning. So I'm going to come back to that and really build that out more. Meeting people where they are, that idea of recognizing that people have many potential competing priorities. And, in the case of responding to the pandemic, getting a vaccine may not be one of them. They might be worried about their insecure food situation or their housing instability or the fact that their children weren't able to be in school. So really being able to recognize that people have lots of different priorities and they might list them in different ways. And I wanted to just mention this idea of the crucial role of business within public health and community health and well-being. And we're going to come back to that, but this idea of sort of partnering with business in the private sector is so essential. And I really like this quote that businesses are struggling to recruit and retain workers. That's the language of business. But public health can come up with solutions that help them with healthier, happier workers. Then you're speaking a language that is understandable. So this idea of trying to understand the points of view of your partners and what resonates with them is so important. So some strategies that people recommended for building those transformative kinds of relationships rather than the transactional ones. First is around earning trust. And some of that you need to start with acknowledging and addressing the structural inequalities and many, so gender issues, disability, bias against individuals with different kinds of disabilities, certainly structural and systemic racism as an example, and then to practice listening and accountability. And I think that this is a really important idea to share with you today, which is to resist the urge to rush to the healing, to skip over the important work. And so this individual said, we can't heal until we have spoken the truth and made room for repair. So some of that, in the case of some of our public and private institutions requires acknowledging the extent to which people may have not have had good experiences with them, may have, within their lifetime or their parents or family's lifetime, some really challenging experiences and may still be having them. And so recognizing and being able to acknowledge that, so that can be part of the conversation. We talked a little bit about this in terms of shifting the power dynamics. And I wanted just to say a word about, coming from an asset-based approach. And I think Vondi alluded to this when she was talking about the community needs assessments. Recognizing that communities have issues that are problems or difficulties, and they do also have significant sets of assets and resilience factors that also have to be recognized. And I can tell you from having been a public health official here in Massachusetts, that we definitely have communities that would say, please don't come and tell us what's wrong with us, right? Help us also be able to tap into what is right and what we can do with that. So I think that that's really important. This, one of the speakers at this Lights, Camera, Action virtual summit was an individual who ran an institute at SUNY Buffalo. And he said that for too long in the university, the community engagement was considered a responsibility, and not responsibility necessarily in a good way, but responsibility as a burden. But now they're having a paradigm shift, and the university views the community as an asset. The community members are actually teaching a course in the School of Medicine called Health in the Neighborhood. And so they're teaching their soon-to-be health providers, what the issues are in their neighborhood and how they can think about their care differently. So that paradigm shift of not having a deficit-based approach, but an asset-based approach is really important. And then this idea of co-creation with learning each other's language and sharing and developing together a set of vision and goals that everyone can align around is a key aspect of this as well. So I wanted to take just a minute to pull on a string that that Jamie alluded to around, community engagement. She said something to the effect of, real community engagement, not just, have a meeting kind of community engagement. And this is a great, from a great toolkit. There's lots of groups that are looking at or displaying a kind of spectrum of community activation, community engagement, participation. This is one that I'm sharing with you and encourage you to look at others, but goes all the way from ignore on the left here, which is when the community has no access to decision-making. And the message that they get really essentially is that your voice, your needs, your interests don't really matter. All the way through to the right, which is around empowering and deferring to community. That is employing community-owned decision-making, putting the community members and residents, at the head, letting them lead and set priorities. And then, the message that you get there is that it's time to unlock the collective power and capacity for transformative solutions. So I think that, along the way, there are these, different places from inform to consult to involve and to collaborate. So I share this with you because as you're thinking about how you are involving community in your work, it's good to sort of ask yourself the question, where are we along this spectrum and where would we want to be and where do we think it's possible that we can move to? So we asked those 1,800 folks the question, where do most of your community engagements fall on the spectrum of the community collaboration that I just shared with you, from ignore all the way through to defer to and empower, and also gave people the opportunity to say, we're not currently working with the community, if that was the right answer. So what we found is almost a perfect bell curve. There weren't a lot of people who acknowledged being at the extremes, at the ends. So ignore or deferring to, or letting the community make the final decision. People were clustered more in the middle, including most of the respondents endorsed the collaboration, which is in ensuring community capacity to play a leadership role in each stage of the decision-making. The difference there between that and empower is that you're not necessarily saying that the community has the final decision, has the final say, is the final decider. But you can see how this varies. And again, I think it's interesting to note that we're clustered more toward the middle within consult and involve and collaborate, but still there's, the majority of people aren't at collaborate yet. So I think that gives us opportunity to think about, well, what do we really want to achieve with our community engagement, and what would it take to move further and to deeper levels of engagement. And then finally, I wanted to just share some thoughts that this group of your fellow practitioners in healthcare delivery and public health shared around ensuring its sustainability and how you evaluate and communicate impact. And again, I'm so happy that Jamie alluded to this at the end of her presentation, because it's one thing to do the work, it's another thing to be able to communicate to understand the impact, and then to be able to communicate it so that that can tie back into sustainability. So one of the first things people really emphasized was the need to invest in sustainability through systems level change. And that requires investing in the time and recognizing that the issues and challenges that we're facing didn't take a short cycle of time to develop. And so we have to give ourselves time and develop a certain patience and pacing to be able to address those. And this, I think this quote is illustrative of this, that the relationship of time and trust. And Roseanne Haggerty, who is focused on homelessness issues and addressing them, said that she thought that they were going faster because they specifically went slower in the beginning to be able to develop those kinds of trusting relationships. Also, speaking of Rhode Island, Anna Novias, who's from the Rhode Island HHS office, she really alluded to the idea that the work that they had begun in their health equity zones isn't done, and they're not done with the recovery after the pandemic either. And because all of the social and core root causes of the inequalities that were exacerbated by the pandemic are still here. And so I think she's alluding to the fact that the partnerships that were established during the pandemic need to be maintained because that work is still necessary. The second, big theme that came up was around rethinking evaluation to measure the impact of the transformative partnerships. And so looking at tools for effective impact evaluation, looking at how you can utilize data systems integration, that data modernization that talked about. I love that idea of the community hub where information flows in from the community-based organizations and social service agencies, as well as from the healthcare delivery system. There's a lot of work that's being done in that. Those data systems often don't talk to each other. And so that's a huge issue. There's issues around privacy and confidentiality and permissions, but still that's an important aspect of being able to look at the impact of what's happening. And then this point of having partner defined metrics, that is ensuring that the community and others that are your partners are also able to say what would be important to them, what would success look like to them, so that they can be part of those conversations. And then, of course, in terms of communicating the value and the impact of partnerships, I would say we heard a lot about tapping into different ways of telling stories, of using the arts to illustrate and convey and activate and energize communities in different ways that sort of a dry report or presentation wouldn't necessarily do. And then being actively involved in the narrative change around not only what creates health, what are the barriers to health, but what are the assets that can be tapped into, and what is the kind of community that you're looking to to create so that you can align and energize people and mobilize the community in that direction. So I think, yes, I will just share very quickly that there were, in addition to the summary of the Lights, Camera, Action summit that I mentioned, there is an action report, and I encourage you, if you're interested, to take a look at that, where there are the 6 themes for taking action, for not just sort of talking and moving from rhetoric to action. And not surprisingly, these have to do with more flexible, longer funding periods, rethinking the idea of how impact evaluation is happening and what it's measuring, and then investing in sustainability, specifically to support the kinds of coalitions. I think it was, Vondi, who said, don't break the band up after you do the information or the community health needs assessment. How do you sustain and support those kinds of coalitions? So that was something that came up. And then, of course, recognizing, acknowledging, and being able to address issues of structural racism and other biases in public health. So I'm going to just stop there because I want there to be some time for questions. And so I'm going to pause.
All right, thank you. Thank you, Dr. Smith. I want to remind everyone that we have posted resources on the page for today's forum, including the Lights, Camera, Action report that Dr. Smith mentioned. So if you're looking to dive deeper, and I see Nick just posted it in the chat. So
great,
very
thank you.
handy. If you want to read in depth these findings, which are fascinating, in particular the part about evaluation, I think. There is a question in the Q&A box, and that is, where is the non-disease or non-prescribed evidence-based strategy funding, if that was identified as a major need according to the CDC Foundation survey?
Well, that's an excellent question, because much federal funding that comes from the CDC does have that disease-based constraint to it because of how it comes from Congress. So it comes with those strings attached before CDC even gets to it. However, I think states have been able to seize some creativity and some flexibility in how to do that, especially if they're able to sort of pull in private sector and other philanthropic funds that they can braid and blend together so that they can look holistically at what they want to accomplish and then be able to sort of knit the disparate funding streams together to be able to do that. One group, again, I would suggest people look at is the Georgia Health Policy Institute, one of I'm sure you're aware of their work. They've done a tremendous amount of work looking at the funding, federal funding that's coming into each state. And I'm sure they've done that for Ohio as well, and to be able to look at just the incredible resources that are coming in and then they have recommendations for how you can bridge and blend and braid those funds.
Great, thanks for sharing that. Well, I am not seeing any additional questions. We appreciate you being with us as well, Dr. Smith, and helping to round out an afternoon of excellent presentations overall. So thank you for joining us, and hope you have a great day. Before others leave, though, we do have a couple of quick poll questions for you. So Alana's putting those up right now. And again, remember to scroll down because there are a total of 4 questions in this set as well. We appreciate you sharing your feedback because it does help us to plan future forums so that they're responsive and relevant to the kind of work you're doing. Thank you all for joining us today. We hope you're coming away with some resources that you can explore further and use as you work to improve the health of your communities and to influence the policymaking process as well. We appreciate all of your engagement and look forward to working with you in the future. Have a great day.